So let's talk about a more complicated case that has all these factors uh, kind of built into it a little bit. So Jack and Jill, he's 59, she's 54. He was initially referred by his urologist. Jack was seen alone at first. I allow the patients to determine if somebody calls me looking to make an appointment, I'll ask them, would you like to come in to see me by yourself first, or would you prefer to come in with your partner? And what's your partner's preference? So I've got some idea, but I'm going to let them make that call because I'm comfortable working either way. And I think it's just part of engaging the patient. So he wanted to come in alone first. He felt self-conscious about his erectile dysfunction. And he complained of a progressively more severe delayed ejaculation, as well as having this more recent erectile dysfunction that had precipitated him going to the urologist in the first place. Now, the urologist had prescribed sildenafil, which helped him initially regain his erectile capacity. But as Jack said, quote, it no longer worked, and it never helped me come. So the urologist had noted that Jack's hormones and physiology were normal, and given Jack's limited response to sildenafil, he referred to me and recommended adjunctive sex therapy. So it's an enlightened urologist. And Jack reported the Viagra's not working at all. Even if I get inside, I lose it. So he also reported avoiding sex because he was afraid of disappointing himself and Jill with the per erections. You know, who wants to do what they don't do well? Even if I get inside, I can't come. So while Jack was very distressed about his ED and D, he was also eager to improve what he described as a once great sexual relationship between himself and Jill, his wife of 20 years, with whom he'd had a wonderful marriage, as he described it. So the sex status in this first session revealed a lack of any direct foreplay for Jack beyond kissing and cuddling, as he only concentrated on Jill. So again, here's something age-related. He quipped, I never needed it before. So many men will find, as when they're younger, that just having a sexual thought is enough to begin feeling a stirring in their penis, and the more erotic the thought, the harder the penis becomes. But now he was unable to keep any erotic thoughts in his mind once he attempted coitus, even when he had a Viagra-assisted erection, because he was distracted by negative thoughts. So again, the sexual tipping point, what turns you on, what turns you off, how thoughts can turn you on, how thoughts can turn you off. Jack says it just falls out. Like, oh shit, this will just not work again. So as such, his arousal level never reached the threshold for ejaculation, even when he had an erection from the Viagra. So he ended up avoiding affection, and he secretly masturbated, which of course made the situation worse. So during the first session, and again, you can begin the treatment immediately if you want. As you're collecting the information, you're also giving feedback. I explained about the normal increased need for direct sexy stimulation or friction and thoughts, fantasy. It's all friction, fantasy, and frequency as one ages in order to continue to function well sexually. I suggested he masturbate, and he liked the idea of the Viagra, so I just went along with that. But to fantasize about the best sex he's ever had with Jill rather than porn. He was trying to make it fun, identify what pleased him, and imagining having sexual success together. Now, from my perspective, there's nothing wrong with using erotica to help increase immersion in the sexual situation to allow ejaculation during masturbation. But I wanted to begin shifting his thoughts back to good times with his wife because they both seemed to have valued that. So Jack's confidence was boosted as we spoke. He seemed hopeful and optimistic. Then Jack indicated that Jill was eager to have sex with him. That was good. And reportedly also wanted to participate in the sex therapy. Okay, that sounds good to me. So we scheduled a follow-up couples appointment with an option for Jill to have some individual session time with me as well. Again, I try and leave it to the patient's choice. And especially if I've seen one of the couple first, I always want to give the other individual a chance to either have some individual time, quote unquote, to make it fairer if that was their preference and sensitivity, or to come in together if being together was more comfortable or preferred. Just as an aside here, for those of you who don't know this little trick, I asked Jack to put his finger on his Adam's apple. In fact, everybody just put your finger on your Adam's apple for a second, those of you out in the audience watching this. Okay, finger on your Adam's apple. Now, while you do so, pay attention to your swallowing reflex, and now swallow with your finger there. Wow, it's pretty uncomfortable, right? It's a big gulp. Well, monitoring an automatic reflex messes it up, whether a swallowing reflex or an erection. So I call this my Perlman's uncertainty principle after Heisenberg. Those of you who've studied physics know about Heisenberg and how measuring something begins to impact the object that you're measuring. So you can never get 100% accurate measurement. But if you're paying attention to an automatic reflex, if you start telling yourself when you're walking, okay, left leg, right leg, left leg, right leg, okay, I'm lifting my fork to put it in my mouth, you just mess things up. And that's whether we're talking about swallowing or an erection. So this becomes a really, really good way to help explain to someone the nature of a psychophysiological response. People say, is it my head or is it physical? It's all the above. And this is a way of just helping to make that real to a patient. So assessing one's erection and orgasmic capacity is not particularly erotic, even if being physically stimulated or if you're taking a PD5, despite the fact that it does lower the erectile threshold. So doing so typically diminishes both the development and the quality of either erection or orgasm or lubrication. And the corollaries to that is that this phenomena can worsen with age. And even for very young people, distressing over just noticeable differences in the quality of their erectile response will result in even poorer response, and it becomes just a vicious cycle. So if somebody's taking a medication and they notice a slight difference in the quality of their erection when they're on this antidepressant, that in and of itself can create a worse outcome in terms of their sexual performance, which may have been precipitated by taking the antidepressant, and yet it's really not the antidepressant itself, the psychoactive medication, that is primarily continuing to cause the erectile dysfunction. It's not knowing how to immerse yourself more in the erotic in order to shift your mind to a sexier response while you're getting that good quality friction. So the next session, as I said, Jill joins us, and Jack reports, good news and bad. Masturbating with a Viagra worked well, but a few days later, we tried to have sex. I got an erection having used Viagra, but it still fell out almost immediately. So I asked them again, I always ask that question, tell me about your last sexual experience in a little bit more detail. Let's start at the beginning. And as Jack started to speak, Jill interrupted him. So per my initial invite, Jill asked if she could speak with me alone. And Jack was fine with that, and I was. And Jack left the room temporarily and went to the waiting room, and I had a chance to speak with Jill privately. Jill described her desire to be with Jack. Now, this is only the second session, mentioning how the foreplay was pleasing and satisfactory for her, but when discussing their coital failures, she grimaced. So I mentioned to her that, I saw your face grimace a little bit, what's up? And she started crying. I want sex because it used to be so good, she said. Sex hurts now. My orgasms are muted. I have no real desire left. It's been like this since my menopause began when I went off the pill 2 years ago. Many women premenopausal, as you know, are being recommended now to stay on birth control pills as a way of elevating their estrogen levels and kind of postponing some of the symptoms of menopause. She described deadened sensations. So Jill reasonably attributed some of their problems to mutual aging. She reported very high intimacy with her husband and deep love. Quote, but we are so confused about our sex problems. My gynecologist says it's normal to stop at our age. I tried using the lube she suggested, but then Jack feels less and it still hurts. She also revealed some important historical information, details for you in a moment. So Jack rejoins us and self-consciously admits he was aware that sex hurts her now. He felt guilty as they'd never really talked explicitly about her pain, but he'd been convinced, quote, my ED and DE was the problem alone. And she'd gone along with that theory, and I didn't want to make her feel self-conscious. So clearly they did have an age-related change, but they just hadn't received any real help in adjusting to these changes, which in and of themselves are so normal. So what was my case formulation? In terms of immediate causes or factors, insufficient stimulation. The foreplay for him is inadequate. He used to just get an erection automatically, and automatic erections are just not going to happen for him anymore. His cognitions are non-sexual. I'm not hard enough. I'm hurting her, etc. I ruled out substance abuse. Remember the three things you want to evaluate and have ruled out in the evaluation? And one of them was things you may need to bypass or pre-treat. So I ruled out substance use issues. They had one glass of wine, which actually probably helped before they had sex typically, just to be a little more relaxed. She clearly needed a consult regarding her pain. I wanted her to get a pelvic exam, labs, etc. What about mid-level factors? In this case, there were some relationship issues in the sense that both were really stuck on wanting to use their previous sexual script. So what was my initial treatment plan? I actually recommended, typically I do 45-minute sessions, but I adjust the time based on need and discuss that with the patients at time. And sometimes in the moment, just at 45 minutes is up, but if you need, we can take another 15 minutes. And I do bill for that time then, but I let them know all about that ahead of time. But I recommended 90-minute sessions initially in 3 parts, 2 individual sessions with her going first, because I really wanted to make sure I understood what was going on with her, and then a conjoined session. Now, I often work with clients' existing physicians. This is good in 2 ways, or more than 2, really. Number 1, it's their choice. Number 2, it does generate referrals. If you do a good job in helping somebody's patient, they're more likely to become aware of you, and it does generate referrals. And I would tell all of you that's one of the best ways of increasing your referrals is by communicating with the physicians who are treating the patients as well as yourself. But in this case, Jill agreed to my recommending a new gynecologist consult for a second opinion. In my opinion, I didn't share this with her explicitly, but I thought her gynecologist really made a serious mistake in telling her that, oh, this is just what happens to people your age, without offering any kind of guidance about what can be done to assist. She just basically took away all hope from the patient. It was an error. So I wanted to recommend a gynecologist that I knew I would have rapport with and be able to discuss the situation with so we could work together. The couple agreed to a no intercourse rule until further notice, and outer course was okay. Any kind of touching they wanted to do that they enjoyed was fine. I did recommend that Jack limit his masturbation to once a week to increase awareness of his likes and dislikes, but for now, he was not allowed to have an orgasm. And then I also told Jack, and we can talk a little bit more about this momentarily, that he would eventually be successfully weaned from using Viagra. As I mentioned before, I believe in weaning people from these medications when possible, so that they are available as someone further ages or has some infirmity, so that you've got something to fall back on that'll actually be of assistance. So what did this new gynecologist tell me? The diagnosis, quote unquote, severe vulval vaginal atrophy. The vagina only admitted 1 finger on examination, with adhesions between the vaginal walls. No wonder it hurt. So the recommendation of the gynecologist was for topical intravaginal estradiol cream nightly for 2 weeks, then reduce the cream to 3 times a week. And once she was estrogenized, to use soft dilators to remodel the vagina, and that she should avoid any vaginal sex until dilation is pain-free, with the guesstimate of which was 4 to 6 weeks. So some commentary on this. I also continued taking history, as I always do, and the deeper history was obtained during the individual sessions. Now, besides ED, he also reported suffering from a non-coital DE, and that was convenient for me. By that, I mean he was unable to ejaculate with either manual stimulation by his partner or oral stimulation by his partner. And that may seem surprising to some of you, because you'd think the degree of friction would be adequate if he's able to previously ejaculate during intercourse. But for him, intercourse was so psychologically exciting that contributed, again, sexual tipping point. So you had good, sexy thoughts and you have good quality friction. Whereas with the oral sex, and you'll understand why in a moment, he felt he was imposing a little bit on his partner. because he was too much the center of attention and she was just trying to please him with the manual stimulation, oral stimulation. And for deeper reasons, he was uncomfortable with that. You'll see why in a moment. But again, he was to desist from masturbating an orgasm. The idea being, I'm going to let Mother Nature help to again lower that threshold and to self-stimulate to better understand likes and dislikes, but no orgasm. What are some middle-level causes or factors that came up? She had a relatively high level of anxiety and depression. Number one, the lack of treatment options offered by her gynecologist had essentially created a reactive depression, and mutual misinformation there had created really despair, especially for Jill. She was also involved in a conservatorship issue regarding her disabled brother, where she had taken on this family responsibility for him, and that was very stressful for her. And in terms of partner issues, as I mentioned before, both were stuck on longing for a past sexual script were always automatic, easy, and satisfying. What about deeper factors? While no violence occurred in the home, Jill's alcoholic father intimidated everybody and had open affairs. He also engaged in childhood sexual abuse with her, which began when she was only 6 years old. The abuse included manual, oral, coital, and anal ejaculation on the part of her father. It stopped when her parents divorced immediately after she, at age 13, revealed the abuse to a guidance counselor who reported it. Then she really surprised me after telling me all that. She goes, "Oh, by the way, did Jack mention his mom's suicide?" So back to the point of how I keep secrets, what I do with them, I asked her permission to be able to let him know that she had mentioned it to me and that I'd like to inquire about it during the individual session and make sure I better understood what was going on in terms of his own past history, because he hadn't mentioned it. So what were some deeper factors? Clearly his mom's suicide. No great surprise. He had some guilt and subsequent abandonment fears that stemmed from that. She had her childhood sexual abuse by her father. So is all these deeper issues relevant or not? What do I do? What would you do? So yes, her pain triggered abuse memories, risking contagious association with Jack. Yes, he was oversensitive to women generally because of these abandonment fears. Remember what I said about his discomfort being the center of attention and imposing on her to stimulate him manually and orally, and how that made him uncomfortable. But for Jill, his sensitivity and oversensitivity, if you will, to women was actually a positive given her abuse history, because his oversensitivity made Jill feel safe, in control, and especially during sex. So I updated my treatment plan. I spoke with a new gynecologist regarding Jill's potential risk of even greater anxiety and depression caused by treatment stress. I was concerned that the stress of the treatment might exacerbate her depression, or I was also worried, what if some of this stuff starts, triggering some, memory, anxiety, and kind of a throwback situation. So prophylactically, the gynecologist decided, along with my guidance, to prescribe 5 milligrams of Lexapro daily. She had had a previous use of Lexapro historically for depression, and that was actually after a child was born to them, and it worked very well. Otherwise, I proceeded as planned. Why? How come I wasn't taking all this heavy stuff more seriously? Well, I took it seriously, but I didn't feel that the deeper factors were currently meaningfully maintaining their sexual dysfunction. So it's all about timing, right? How do I know? I wasn't sure. But what was their history? Both of them described a really good marriage with really good sexual interactions, good sexual activity, good feelings of satisfaction and meaningfulness together for many years in their 20-year marriage. Now, they still had the history, this deep history that we just uncovered. And yet everything was fine for many, many years. So from my point of view, I was willing to take the chance that we could deal with more of the here and now and not get lost going down the rabbit hole of exploring these situations where, if anything, I probably would have greater risk of triggering more anxiety or depression or worse. So what happened? What transpired? Her vagina gradually improved with the estradiol cream. She used the dilators 3 times a week. Now, then she started using almond oil that they had liked in the past, and they began massaging and sexually touching each other again, and she was orgasmic. He wasn't yet, but she was orgasmic, and both of them were thrilled with that. So enhancement techniques were discussed during the next few sessions. As their sex life improved, so did their mood and confidence. And again, while they're not having intercourse yet. Time was spent helping Jill reintegrate positive feelings about herself by emphasizing her historical resilience and coping skills. So I took the negative that had happened to her, talked about how well she had gone on in her adult life, how successful she'd been, and really emphasized the degree of resilience she had and the coping skills that she had. I also gave her some guidance on help with other family of origin stresses, like her disabled brother. Jack was given some assistance with his stresses at work. So again, while these things were not directly mitigating the sexual functioning, I felt that if they weren't managed down the road, you could end up with a relapse as these additional stresses began to interfere. So I wanted to begin managing some things that I thought might have a negative impact in the future, just to sort of take some of the tension out of the situation. This was done, primarily using cognitive restructuring throughout all the sessions. At their 9th visit, they asked for the conjoint session to be first. If you remember, I'd asked to meet with her first and then meet with him and then meet with them together. So at the 9th visit, they asked, can we just come in together first? And I said, sure. Again, I allow the patients to give me the lead, if you will. And they sheepishly reported having had successful, quote unquote, unauthorized intercourse with mutual orgasms. Hers were still muted and different, but they were both very, very pleased, very delighted. But because sex was so good, they decided to try again the next day. This happens so often, and it's obviously a flight into health. It's a bit of a problem. No surprise, she was tender, and while he was able to erect an orgasm this time, she had pain again and expressed concern for their future. So I provided reassurance and some additional sex education about aging, foreplay, and lubricants were now resuggested as opposed to her first gynecologist's original suggestion of them. This is now an appropriate time to use them. But I did tell them to postpone coitus, and she was to self-explore with a 3rd and 4th dilator and not rush back into intercourse quite yet. The next week, she fantasized about sex with Jack while using the 4th dilator, and she had orgasms twice. That next weekend, returning home after dinner, Jill initiated sex, and they had successful intercourse with mutual synchronous orgasms. This occurred again the following week. By that point, I was seeing them every other week because I wanted to give them a little more space. Treatment was terminated after 3 more briefer follow-up sessions. By that point, I was just seeing them conjointly. Jill will consider additional medical intervention in the future if needed. And for now, they wanted to just enjoy their renewed sexual intimacy. Now, what about follow-up and some follow-up tips? I always try and schedule a follow-up session as termination is imminent, in that having that date, that appointment, I believe helps keep the lessons learned more predominant in the patient's mind. They'll see in their schedule, they're supposed to see me in 6 weeks. And they'll be reminded of some of the conversations we've had in the therapy. And I think it's a way of keeping the therapy in their mind, some of the lessons learned in their mind. Also, if there's a relapse and patients haven't returned earlier for reasons of their own choice, because of either shame or embarrassment, it allows them to show up, quote unquote, disgrace-free. And you can re-engage and have an opportunity to help them before things really go to pot and become much worse. Now, in this case, the news was good, and the couple reported an average of 3 successful intercourse experiences per month, with occasional manual or oral sex to orgasm occurring for variety's sake. And both of them were able to orgasm that way at this point. They enthusiastically reported that their general stress levels about sex were lessened, and it was no longer a big deal at all. Quote, we no longer need to line up our ducks I used to use that expression with them. Got to line it all up. I understand this and that, but like, let's put it all together. So everything was just so, like you were teaching us in sex therapy. Instead, it's kind of like it was in the good old days. It's somehow a bit different, less intense and automatic, but in a nice, relaxed way. So thank you all for listening.